just want to start out by thanking everybody for joining us tonight. West Point Women is privileged to be able to put on this panel this evening. And thank you so much for joining us to learn about how some of the leaders in the medical community have responded to and continue to respond to the COVID-19 pandemic. This webinar is the first of 4 quarterly webinars that are designed to connect and inspire West Point women and colleagues as we celebrate 45 years of women at the Academy, as well as lean into what is now going to be the 2022 Women's Conference. And I have the privilege tonight of introducing my classmate, MAJ Melody Nolan, as tonight's moderator. After graduating from West Point in 2004, Major Nolan graduated from the Uniformed Services University of Health Sciences in 2009 and completed her residency in gynecologic surgery and obstetrics at Madigan Army Medical Center at Fort Lewis, Washington in 2013. Her military career has found her in the clinic, supporting special operations in Guyana, and giving back to the profession in a myriad of ways. She continues that service of giving back tonight as she's joining us. Melody and all of our panelists, thank you for selflessly giving of your time and your stories in order to give us all a perspective on COVID-19 and the pandemic response that you have all been intimately involved with. Melody, take it away.
All right. Well, thank you so much, Jackie, for that introduction. I wanted to say good evening to everyone, and thank you to our panelists. What an honor to be able to talk to these amazing women tonight. And I look forward to hearing all of your questions as we kind of talk about the past year. So COVID-19 is the first global pandemic of its size in over 100 years. And so we've been fighting this virus for over a year now. Just to think back that, the shutdowns were occurring, in March a few weeks ago, a year ago. And so we wanted to come together to discuss some of the leadership challenges that we've had, the lessons that we've learned, and then discuss perspectives that we've developed from all over the country. The US has had one of the largest outbreaks in the world. And so we've had over 30 million documented cases to date. And unfortunately, we've lost over 550,000 Americans to the virus. I've been talking and listening to many different perspectives as how we as leaders in the military and the civilian sectors have handled the stages of the pandemic. And it's both amazing and absolutely heartbreaking to hear everyone's stories. And we'd like to share those with you guys tonight. So we've assembled a panel of West Point women who've seen, heard, experienced all parts of the pandemic. And I'm incredibly honored to speak with them tonight. So our first panelist is Major General Telita Crosland. She's currently the Deputy Surgeon General and the Deputy Commanding General Operations of DHHQ. She's a graduate of the United States Military Academy in 1989. In addition to her doctorate of medicine from the Uniformed Services University, she holds a Master of Public Health from the Uniformed Services University and a Master of Science in National Resource Strategy from the Eisenhower School. Our second panelist is Darlene Cookie Wilson. She's been working as a COVID-19 emergency department and ICU travel nurse. She is a 1985 graduate of West Point, served as an Army aviation officer and a public affairs officer. She graduated from the University of Texas with her RN and MSN, and the University of Cincinnati with her psychiatric mental health nurse practitioner degree. She volunteered for travel assignments when the COVID outbreak occurred to Queens, New York, and the Rio Grande Valley, Texas, just to name a few. And she is currently working in Dallas, Texas, as an ICU nurse. And then our third panelist tonight is Commander Sara Jager. She's a pediatrician serving as a chief medical officer and chief of pediatrics at a tribal hospital on the western edge of the Navajo Nation in northern Arizona. She graduated West Point in 2000. She served as a military police officer and deployed to Baghdad in support of OIF in 04 and 06. And then she transitioned to public health service officer and graduated from the Uniformed Services University in 2010. She completed her pediatric residency at the University of Utah in Salt Lake City, and she's been working extensively to fight COVID in an underserved population. So thank you guys all so much for joining us. The first thing I'd like to kind of talk to our panelists about, please tell us a little bit about who you are, where you were when the COVID pandemic outbreak occurred, and then what your response has been over the past year.
Hey team, I guess I'll start us off. Thanks for the kind introduction, Melanie. I appreciate it. And I really do appreciate the opportunity to spend some time with all of you this evening. As described, my role currently in Army is the Deputy Surgeon General, and then I'm the Deputy Commanding General for Operations. So I got the opportunity to straddle between the folks actually executing our hospitals and our clinics, and then our Department of Defense as we responded to it. And as I described what we did and how we led through it, I kind of bucketed in what the challenge was. And as most of us know, this was a pretty unique challenge, being a pandemic. And for the DoD, it created a competition of resources for us within our own country, right? So we had medical assets, medical resources that are focusing on American citizens, right, inside our own borders. And the challenge was for us to support, as a Department of Defense, a whole of government response to the communities around, of which we were part of those communities. And working through that tension and friction with each of our hospitals and clinics that are trying to care for a community, but also being pulled to support the prioritization of the President and the Secretary of Defense. And so that was challenging. It's a novel virus, so there was a devoid of answers. And as most of us know, there's a bent to action within our Department of Defense. And the idea that we weren't going to do something really created a lot of pressure and groundswell from our most senior leaders that we've got to do something. And a lot of, especially early on in the March and April timeframe, what was that something? And you know, if you watch TV, sorry for my dog back there, TV, a lot was about testing. And so to be quite honest with you, we moved out with testing within the Army, with the force of the entire United States Army. And we did that very well. Whether that was a thing that needed to be done, we can discuss that later, but it was something that could be done. And there was a bent to action. Within the DoD, there was a bigger challenge. All right, you guys are gonna have to excuse me. If I don't want him to bark, he's gonna have to sit up here with us. So within the DoD, there was a bigger challenge of how do we come together as a department across all of the services, Army, Navy, Air Force, Defense Health Agency, to advise within the OSD, which was advising the whole of government. And then how do we save lives, and how do we support, and how do we take care of our staff? So that was a leadership challenge. One of the things we did that I think is a lesson learned and a win, and I'll be honest with you, the epiphany came to me talking to my niece, who is a ER nurse in Atlanta. And I recognized we had to flatten communication. We had to get in an environment when there's not a lot of clarity, there's not clear understanding. We really had to we had to flatten and get the team that was on the at the front lines in the room with the leaders who would think of all these things we should and needed to do. So we held a daily clinical work group, and that had three big objectives for me. One was, as we as strategic leaders were seeing the challenges and quite frankly trying to come up with solutions, how are those solutions impacting the organizations that were dealing with it? So it allowed feedback very quickly. The second thing that it did is it really allowed us to disseminate information in an environment where information was unfolding literally daily. A good example is we reached out to some of our reserve teammates up in New York. And before we were in the throes of COVID ourselves, we had a chance with one of our reserve docs to talk to the clinical work group and share their lessons learned. You know, oftentimes we do lessons learned at the end, but our ability to incorporate lessons learned real time, I think, made a difference in our ability to provide our beneficiaries and our service members and our patients the best quality of care that we could. And then the last thing, and probably the most important thing I think that clinical group allowed us to do is, in medicine, when you have ambiguity, I got several clinicians on the line, there's an uncomfortableness that I alone am going to make a decision that's not going to be in the best interest of my patients because I don't have all the information. And I'm being stretched. I got to worry about my family and me bringing it home. I got to worry about having enough PPE. I got to worry. And I'm still not even sure the right way to treat this. And I just wanted to create a forum where we could talk about that, and that could be recognized and owned at the senior levels. And we were going to do our best, and that's going to be okay. It's going to be okay. we're going to do our best with the information we have, with the resources we have. And I didn't want our clinical teammates carrying that weight at the individual level. I thought it was important that we share it and everyone see that other people are struggling with that. And as a senior leader, for me to underwrite that you're going to do your best. So the last thing I wanted to say that we had to do was, you know, we're the Department of Defense and we're a military health system. And so you certainly don't want to see a difference between the Army and the Navy and the Air Force and the Coast Guard and the Marines, right? We had to figure as senior leaders, how did we balance what our services thought was important, but what medicine as a community, as the subject matter experts, we're going to advise the Department of Defense leaders. And I won't lie, that got sporty at times. That got sporty because all of those senior leaders in the Navy, in the Air Force, and the Army had their ideas. The secretary had their ideas, and the medical guys really weren't always able to inform those ideas. So let me leave it at that. What am I most proud of? I'm most proud of the ability of the entire team to adapt. And to be agile and to take something, operationalize it, and then literally 2 weeks later, we have to do something different, either because we pulled something out of one of our facilities or we got another mission set. And I never got the impression that everyone wasn't trying their best. No one quit in place. And we had a lot of good reasons to buckle, and we didn't. So I'm really proud of that. I'm proud that we were able to come together and support each other. That clinical work group was well attended, and we had good conversations, and we talked about what was difficult, and then we got after it. And what I'm most worried about, because here we are a year into it, what I'm most worried about is that's a lot of strain. We've put a lot of strain on our healthcare system and everybody that works in the healthcare system. And they're all human beings. And are we in a good position to see that strain and address it and to provide the care and the room, right? I really struggle with that. In one breath, I'm telling folks, take care of each other. And in the next breath, we're pulling resources that make you work harder. And both I and the Surgeon General are struggling with that, and we're working on that. The other thing that I'm worried about is we've delayed care throughout our country. We delayed care within our healthcare system, and what does that mean for our patients? We're going to see some outcomes that are going to be problematic. And what are we doing? Do we have the bandwidth to see what that looks like and plan for it? And then the last thing, before I choke my dog out after I'm done, is I worry about our training and education for all of us. Right, that this isn't a military unique thing. Everybody is struggling with, whether it be graduate medical education, nursing education. We have skewed a year of folks' education, including my 11-year-old. And so, what's the impacts on that, and how are we going to address that going forward? So, those are my initial comments on the things that we did, particularly focused on the leadership challenges, how we approach some of them, and some of them that I still have some work to do. Thank you.
Ma'am, thank you so much for sharing those comments. You know, I think this idea of communicating, and for the first time, medical officers were having to communicate the science with the line commanders and make sure that everyone was on the same page, and what a struggle that was in some instances. Cookie, do you want to go ahead and go next? She might be having a little bit of issues with her internet. So Sarah, do you want to go ahead and go next?
All right. Hi, everyone. Thanks for having me tonight. I'm Commander Sara Jager. I'm class.
Okay. I think I got it.
Okay. Hi, everyone. Thanks for having me. Darlene, did you want to speak next? No. Okay. So I have been serving at Tuba City, Arizona, in northern Arizona, about an hour and a half east of the Grand Canyon for the last 8 years. I'm a pediatrician by training. I've done lots of cool pediatric stuff. In 2018, I was the Female Physician of the Year for the Public Health Service for my time as the Chief of Staff as a junior '04. And so when COVID hit us in March of 2020, I was not the CMO. The guy before me was 70 and immune compromised and morbidly obese. And my CEO came to me and asked me to be the chief medical officer. And what is a chief medical officer? The doctor in charge of all the doctors and all of the ambulatory care at 3 sites, including the main hospital site. And so we are a very rural place. We see about 150,000 outpatients a year on our tribal facility. Our nearest referral center is 75 miles to the south in Flagstaff. As a pediatrician, my nearest pediatric hospital is 3.5 hours south in Phoenix. And so we're remote. There's no pool of people to upstaff from when this hits your community in a rural area. And so managing the inpatient, we have 70 inpatient beds, including an ICU, med surg, a peds ward, level 2 nursery, and we're a level 3 trauma center. So trying to manage all of those things and keep care open despite this pandemic hitting us. Our super spreader event happened in a Church of the Nazarene on March 6th in Chilchimbato, Arizona, about an hour to the north. And that small clinic and ER was very quickly overrun. On a weekly average, we probably intubate 3 patients a week. At our worst during this, we intubated 9 a day. And so trying to figure out the resources of how to get those patients out. We don't keep intubated patients in Tuba City. All the drips and all of the requirements for flipping and ventilating patients it's a higher level of care than our nurses and physicians provide here. And so we transport every patient out. I think of the 400 plus patients with COVID that we've transferred through our facility, about 138 have died, 40 of them in our facility and the rest in Phoenix or Flagstaff. And so it wasn't a job that I had before the pandemic, and jumping in the middle of a crisis when the job was in shambles from the guy before me, and the administration and the medical staff relationship was very poor at the time. It was just not one of my mentors said, Sarah, you're gonna have to eat a lot of shit. And I did. And I worked really hard to improve the relationship and make sure that our medical staff was safe, because that idea of forced protection, it doesn't exist in the medical community like you think it should. We work when we're sick, we come to work sniffling and coughing, and we never ever miss work. And the thought that now this pandemic was going to take all of us out, and that ambiguity that General Crosland spoke about, we didn't know who was going to get sick. We didn't know how we were going to get sick. I remember I was out for a run one day when 50 Italian doctors had died on April 1st or March 30th. And I remember just thinking, this is coming to us. And that burden of having to be the person that makes those decisions to keep your staff members safe was really, really hard for me. I want to talk about the staff that we needed, the stuff, and the space. So like I mentioned, we didn't have a pool of nurses to pull from, and that across this pandemic has been our greatest challenge, was bedside RNs. I had plenty of physicians to do some care, and I put them to work doing a multitude of other things. But I had to take CRNAs from the OR, since the ORs were shut down, and I put them back in the ICU as bedside ICU nurses. Some of them hadn't been there in 10 or 15 years, and that was really hard. And then my nurse practitioners all were Commissioned Corps officers. Most of the 1,100 employees that we have are direct hires. There's about 30 Commissioned Corps officers at my site. I've had to take them out of patient care and testing and follow-up visits, and I put them at the bedside. That was really hard. Some of them had gone right into nurse practitioner school out of nursing school, and they were unprepared for some of the things that I asked them to do. We had no public health department here on the reservation. So I don't know that most Americans know what living on the res is like. I'm in the middle of nowhere. The hospital provides the housing. You could take the COVID out of the OR plume and it's gonna fall into my window on my house. That's how close I live to the hospital. And so we all live and work and play together in the same area. And so when all of the community gets sick, you know, all of the employees, the nurses, the CMAs, the finance, the HR, when they all come from the community that is sick, they all get sick too. And at any point during the pandemic, we had 8 to 10% of our workforce out due to COVID contacts or COVID illness. And that also means that the hardship, the heartache of what has happened to the Navajo people during this pandemic and as an epicenter means that all of your employees, even if they're not frontline healthcare workers, are seeing this tragedy. For example, I have 3 admin assistants in my CMO office. One was sick with COVID herself. Her sister is our compliance officer at the hospital. Her husband was intubated for 35 days and ended up dying. The second one, my credentials specialist, again, not a frontline healthcare worker, but both of her parents caught COVID, were intubated and died, intubated in Tuba, and then died in Phoenix 3.5 hours away. And so when you're trying to figure out how to Zoom end of life visits, or how to get families to come in for end of life visits, and how to allocate PPE when you don't have enough PPE, but you know that these end of life visits are important. These are your own employees that are suffering. And that was really, really hard to watch. And then when our own medical staff got sick, the day that we intubated our PA from the ER was just one of the hardest days that we faced. And that was in April. And the Navajo Nation has actually had a higher incidence and prevalence of disease in our population than New York City at its peak. And so this has really hit us hard. And as bad as March and April and May and June were, November, December, January were worse. So talking about the staff, one of the greatest days that I had was the day that the National Guard brought the DMAT team to Tuba City. And I just looked at that helicopter and a tear came to my eye and I was like, hello, old friend. Like I knew that someone had heard our cries for help and that we were being overrun with COVID at our hospital at the end of March. And one of the most useful things that the DMAT team told me was, help isn't coming. Everyone in the whole country is facing this crisis and everyone was holding tight to their assets. So while the western side of the reservation was going gangbusters with COVID, the eastern side wasn't giving us any kind of support or help in the form of resources, PPE or people. And we just had to make do with what we had. And that was one of the most useful things that I held on to throughout this entire 11 months in this job. I had to put dentists and dental assistants to sewing. We didn't have enough gowns, so we set them to sewing, and it turns out they are very useful at many other things besides dentistry when the dental clinic is closed. And they sewed 350 gowns for the hospital and sent more across the rest of the reservation. Physical therapists, dentists, the CRNAs that I mentioned were all reallocated into other positions. And General Crosland mentioned the adaptability of all of the people. Healthcare is not very nimble, and particularly Native healthcare is not very nimble. So to try to change these jobs and these systems overnight, it really did take a pandemic to make that happen. And so I can see how that's, across the services, that's been very useful. I had to assign people to do tasks that I knew might put them in harm's way: triage officers, PPE czars to train us on how to do PPE donning and doffing, epi team leaders, how to coordinate the public affairs response, because hospitals don't just have a public affairs officer. Certainly ours didn't. We have one person and she does Facebook like every other month or something. So to try to get the information out to the community was really hard in a way that they would trust us. All they knew is that people were going into our hospital and not coming out, and they were very afraid to come to the hospital for care, and that is still affecting us. The other stuff that we needed, the PPE just didn't exist in the beginning, so we were certainly reusing it, decontaminating our N95 masks, how to figure that out, how to send them to Flagstaff to do the hydrogen peroxide, and then get them back. All these little things that we didn't know how to do in the beginning, and we really had to develop processes to make it happen. And like I said, we're not a nimble organization, and so trying to figure out all these little steps was actually really hard. Our hospital was built in 1967. It was one of those IHS dinosaurs that somebody built and then forgot, and it's just been functioning on its own ever since. trying to figure out where in the hospital your ventilation system goes. So usually ORs are positive pressure to keep the germs out. And now we had to keep the COVID in on just one. And so where does that vent to and how does that go, especially when you are asking people to wait in the parking lot or you have all your triage testing out in the parking lot? Are you just venting out to your employees in their houses or in the parking lot? So I'm trying to figure out how to retrofit a 1967 building to put negative pressure in dental rooms, OB rooms, and of course the respiratory care center so that you can do more high flow and ventilator management pre-transport in more rooms so you can use them all up. We converted our pediatric ward to a respiratory care unit. And so pediatricians like me were put into other jobs because they didn't need to do inpatient care, thank God, because kids weren't getting sick. We had a tremendous amount of pressure to reopen. It felt like the whole country shut down, but there wasn't coronavirus everywhere at that time, but there was coronavirus here in Tuba City. But only about a third of our budget comes from the federal government. 2/3 is billed through mostly Medicare and Medicaid or private insurance. And so when you don't have money coming in, how you continue to pay your employees, that was really hard. We had a furlough list with names. I had surgeons that I had to put names to that I was going to cut, and dentists and physical therapists, people that were really useful to me in the pandemic in other ways. And I had to convince our board of directors and my CEO that we needed to keep all of the people. And so one of the hardest things I had to do was look all of my colleagues, and I'm a member of the medical staff, right? But I'm pretty well protected. My pay didn't get cut because I'm an officer, but they all had to take a 10% time and pay cut if you made more than $20 an hour. So while you're afraid of taking your coronavirus home to your family and I'm asking you to do these really hard things without the right amount of PPE, I'm also going to take 10% of your pay. And that was really hard, especially since other IHS sites on Navajo Nation, like Chinle, the next hospital to our east, were paying 25% over just if you even stepped on the hospital campus. So it just felt very, very inequitable. And that was really hard to do. We took that pay cut for 4 months, and we didn't know that federal money was going to come in. And we've since gotten about $43 million, which is about a quarter of a budget for a year of what we bring in for our hospital. So trying to figure out how we were going to continue to provide care with all the services that we could provide pre-COVID, and buying all the stuff that we need and renovating a hospital without much money coming in was really, really challenging. And then what were the priorities? So those were some of the harder things that we had to do with space and stuff and staff. Our vaccine, I do want to talk about how our vaccine rollout has gone here, because I feel like Navajo Nation learned a lot in this process, and we could be held up as a beacon for what other hospitals or other sites could be doing. So we went from a 23% positivity rate at the end of January to we're down less than 4% 6 weeks later. So our fall surge was really bad. We, again, were full. I was very afraid that Arizona would fill up and we wouldn't be able to transfer our patients out. We got to about 90% capacity in Arizona. So we were always able to transfer our patients, even if it took several hours of waiting on the surge line for a bed to open. So we didn't actually have to hold on to patients that were intubated longer than 24 to 48 hours, which was really helpful for our staff. But sometimes patients were too sick and the accepting facility wouldn't accept them, knowing that they would just die there. So watching a patient that you've intubated and you thought you could save die in your ER was really hard on our staff. And our internal medicine doctors. And they came to me and they said, Sarah, we know it's gonna cost us money because we're gonna do this on overtime and you're gonna pay us. But we wanna go out and do the vaccines, because this is the way, to see that people have survived, that they're healthy, and that they're so grateful to get this shot is really our morale booster. And so we have done about over 14,000 vaccines. Once the EUA was published, we were putting vaccines into arms the next day. Indian Health Service the national government had prioritized Indian Health Service, and so Tuba became part of that allocation. And so at 16 and over, we've been able to do everyone. And what we did is we shut down clinics and put the resources to getting it done and said, we're going to do these in mass vaccination events. And we've really rolled this out, and it has made a huge difference in our vaccine burden. We knew, looking at our COVID ward, that age 50 to 65 were filling up our beds on the inpatient unit, and that our only way out of this was to vaccinate that population. It seems like COVID was a perfect killing machine for Navajo Americans. It attacks the obese, the people with type 2 diabetes and hypertension, and that's many of our 50 to 65 population. And so vaccines have saved us, and I'm happy to talk about vaccinating. We had Pfizer and Moderna, and we've recently added the Johnson & Johnson vaccine, and we're mostly trying to use that in the ER, where we know that, you know, the mental health and the alcoholics aren't going to come back for a second shot, and so we're prioritizing those kinds of patients that are a one and done kind of shot. I did want to say that most of the things that I've had to do as the chief medical officer during this response had nothing to do with medicine. Yes, it's nice to be able to read the literature as an MD and figure that out, you know, be able to read the science for myself, but mostly the skills that I needed were my Army skills, which is why I think my CEO picked me to do this. She was an enlisted member in the Army herself. She was a medic, and then she was an Army nurse. And she knew that I had the skills to be able to get things done. While my leadership style may not always be welcome in every instance, the only rule that she said was don't curse, and I did manage to make that happen, at least publicly. And so there's a few things that I think that being a West Point woman and an Army leader helped prepare me for this role. The first was, when in charge, take charge. I didn't want this job. I didn't have the confidence to think that I was going to be able to do it, but I knew it was there was a leadership vacuum and somebody needed to do it, and I was willing to do it for my colleagues and my friends, and to keep our medical staff and nursing staff safe. And I was afraid and uncertain every day, but that phrase just coming back, when in charge, take charge, and I jumped in full force, and I was able to make a lot of difference. I think that the other saying is lead from the front. You know, go out and check on the areas. I was in the triage tent. I was rounding on the weekends and the nights in the red units, red ER, and the red ICU, our COVID units. And the first day that I walked into the COVID ER, I got a standing ovation from the staff in there. They said, "You're the first administrator that has come into this area." Everyone else was too afraid to come in and see what was actually happening inside of our units that were treating patients. And so that was pretty shocking to me. It never occurred to me to not go in there, but that leading from the front, seeing that you're willing, that you're out there, is not just a morale booster, but it's the only way to learn what's actually happening. I was swabbing noses at Blitz events. I'm the vaccine giver at vaccination events, in addition to answering the media questions and things when I'm out there. I think the other thing that the Army and West Point prepared me for was this idea of the 5-paragraph op order. Like, you hated that as a lieutenant, right? Like, if I have to write another rifle op order, I'm going to kill myself. But planning an operation from start to finish is not something that doctors are trained well to do. The IT required, the public affairs required, all of the information publishing that's required to get everyone on the same page. I had that ability, and I don't think that all doctors, and especially most hospital administrators, can't plan an operation from start to finish. So that was one of the things that I was actually really grateful for. And then finally, my physical fitness. So I was an athlete at West Point. I was recruited to run track. I ran indoor and outdoor track, and I loved Buckner, and I loved the obstacle courses, and I loved plebe drowning. I didn't love being late to math class afterwards. I think I got some hours for that once, but I love the physical aspect of West Point, and I'm an endurance athlete now. So I run rim to rim to rim in the Grand Canyon. I'm an Ironman triathlete. I qualified for Ironman World Championships in New Zealand. That'll happen next year. Like, it's just like what I like to do, but I relied so much on being physically fit. I didn't realize it was that this job would take all of my talents. And that was one of the talents that I really, really relied on. After I was done rounding and being out there all day at these long events, then I would come home, I'll come back to my office and do my 6 hours of email, 400 plus emails a night. And sometimes in the office till 11 o'clock at night. I didn't get my training in, but my training carried me through those really, really, really long, stressful days and allowed me to stay focused even when I was physically and mentally exhausted. So I was really grateful to have been an athlete. I had a first sergeant once tell me, if you expend 90% of your energy getting to the fight, you're no good to me in the fight. And all I could think was First Sergeant McIntyre telling me that, and how grateful I was that I was still physically fit at 42 or whatever I am. So I underestimated how important that would be. Thanks, Melody.
Sarah, thank you so much. I mean, that is just absolutely amazing how you were able to inspire people that you were working with in kind of the worst conditions possible, especially being resourceful. And I'm sure every day that you walked into the clinic, it was another just explosion or disaster that you had to deal with. So I really applaud your resolve. So definitely one of the things as healthcare providers, you know, I've talked to a lot of people over the past year. They've described kind of just this isolation and loneliness, and definitely having some trouble with all of the social distancing that's been going on. So do you have any examples of any personal experiences you have with this, or how you kind of attempted to cope with these situations?
Melody, can you hear me? I'm happy to answer that first, I guess.
Yes, we can.
So I think for a lot of the healthcare workers, and I know that Cookie wanted to talk about this a little bit too, we felt like we were going to bring this home to our families. And, you know, the CDC said it lives on all these surfaces and people are wiping down their groceries. We've gotten past that, but in those first months of the pandemic, I was confined to my little condo in Tuba City with the bad air filtration, right? And I wasn't coming home and I wasn't seeing my hospital. It was like a deployment, except you still had to pay your bills and feed your dog, right? And so it was really hard to manage all of the requirements of doing this job and committing so wholeheartedly to it while still maintaining your real life. When I was in Baghdad, somebody did my laundry and I showed up to the GFAC and my food was hot. But here I actually had to like feed myself and make sure some of the other chores were done. And then in doing that, like we had just separated. I didn't sleep in the same bed as my husband for 4 months, even after I moved back into my Flagstaff house. And you know, it's very isolating. I also felt like from the American people, similar to how I felt in Iraq. There's a very small number of people fighting this disease, and everyone else gets to live their life however they want. And I felt I felt very angry at America for treating their healthcare workers like this, because, you know, I would see the Super Bowl parties and people visiting their family, and I had given all of that up because I knew that it was unsafe for them. And I just felt like the burden of this disease was being carried by few, similar to some of the time that when I was in Iraq.
Thanks, Sarah, for definitely sharing that. Cookie, since you're back on, do you want to go ahead and speak a little bit?
Well, hi, I'm on my third login. I'm so sorry. And with my phone, it's just working. But I did want to say thank you for having me, and but maybe want to come to New York City at the beginning. Well, I was teaching my students at the University of Texas at Austin. I was my nursing student, and quite a few of them had become quite scared of had they made the right choice in the career that they had chosen. And so I, you know, look back on our mission to educate, train, and aspire, become leaders of nation for character. And I told them that they had been trained, they had been educated and trained, and the mission they were going to do, they could do it safely. So I volunteered to go to New York and went to the epicenter. I was at Elmhurst Hospital, and it was just like the movie Pearl Harbor, where we were triaging patients. They were coming in such droves that we would have to name patients triage alpha, triage bravo, triage Charlie, and we didn't have their real names, and they were passing so quickly. It was hard to tell the families if their loved ones had passed. And some of the problems, not only was it difficult getting all the patients and getting the resources, the stakeholders tried the best they could to prepare for what they would need. However, they didn't get it all right. Lots of nurses, lots of, are you hearing me? Am I coming through?
Yes, we can absolutely hear you. Thank you. Yes, we can absolutely hear you. Thank you.
I'm sorry. So a lot of the stakeholders got something wrong. We had, can you imagine not having logistics and supplies and resupplies, and then the patients were sick, as Sarah had said, we had to turn other wards. Most of the floors turned into ICU. So we had ICU patients on all the floors, and they had more nurses and more NPs and PAs, but they didn't have more pharmacists. They didn't have more pharmacy techs to bring the meds, and the priority for medications were those drips that would keep the heart running, or some of the respiratory medications. And because of that, the ER, we would get our meds in buckets, and I had to take my leadership and take all these new NPs and actually new nurses that showed up, and direct them to kind of give them skills. We had one head wall, one oxygen coming out of the wall, and we had to have it for 9 patients. We didn't have enough non-rebreathers, the masks that you put over them for them to breathe. We had venti masks. So we would take the actual gloves and tape them to the end of the venti masks to turn them into non-rebreathers to help these people get to the point that we could at least stabilize them somehow and get them upstairs. So that was very difficult, and it was difficult identifying the people. It was before we had the refrigerator trucks, and then we're able to break down and really get people's names. So the leadership and the stakeholders regrouped, and were able. We also learned a lot about caring for the patients there, so that when I went to the Rio Grande Valley and then over to Guam and then back here to Dallas, we were able to keep more people alive. This has been the hardest thing I've ever done in my life. I've held more hands this year of people dying and taking their last breath than I've done in my 25 years as a nurse. Yeah, we have Zoom calls, and we try and have the families there with the Zoom call, but they weren't allowed to come in because of how virulent the COVID virus was. Guam was very much like your Navajo Nation, where the population, the Chamorros, had that metabolic triad, the hypertension, diabetes, and hyperlipidemia. I'm still here.
Are you still able to hear us? All right, so sounds like a really intense kind of a year for you, and thank you so much for sharing that, Cookie. We really appreciate that. One of the questions that is asked by the group is, so I've definitely seen it as a physician, but changes in licensing. And so as far as states delaying how frequently or, kind of postponing when we have to get our licenses renewed. Do you think with a global pandemic like this, when we start looking at licensing of nurses and physicians, that we would start to see almost a national license come about from it? Or do you think we're still going to be restricted to state licensing?
I'll take that. I don't think I can answer for the nation, but what I will for the Department of Defense, one of the lessons learned we had was we leveraged reserves quite a bit. And prior to this, we had a centralized privileging and credentialing process so that when we mobilized them, we didn't waste a lot of time. And that actually turned out to serve us well. And that was a good lesson learned to sustain our ability to at least do the credentialing and have them with a set of privileges ready to go, so that when we called on them to assist, whether to go up to New York City or to go into one of our own hospitals or clinics. So we saw a lot of value in that, and it's certainly pushing DOD to look at and that was an Army thing I just described, but to get to a DOD process where we centralize at least credentialing to facilitate that.
So Melody, at my hospital, we were in a code green, which is our disaster, and that meant that we can do disaster privilege, credentialing and privileging. And as a federal or a 6-3 IHS site, we take licenses from every state. And so it was easy as long as we were in the disaster to get physicians and nurses onboarded. But when we came out of that code green in August, that got a little bit harder. Fortunately, we didn't need physicians to be there so quickly anymore, because we kind of had our processes in place. I don't know. I think it's a money making event for each state, and it's going to be really hard for them to centralize that, because they will have to give that up.
That's absolutely true. I wanted to take a short moment. Let's talk about the vaccine. What kind of facts do you want to set straight about the vaccine, especially for anyone who's personally or family members are kind of vaccine hesitant right now?
The one thing I'd like to share with the team is we were fortunate, and I'll couch it that way, then feel fortunate probably real time, but we donated a lot of talent to the Operation Warp Speed. And it's turning out that that's an unfortunate name, but what it did do is give us, at least me personally, insight to how the vaccine was being developed and how it was being tested, and how we were able to do it at warp speed. If you just look who led it, is General Perna. General Perna is a logistician. And what he brought to the table was the ability to, in tandem, as you develop a vaccine. So for many of the folks, the mRNA, the type of vaccine that is in Pfizer and Moderna, that's not new. That's not a new technology per se. mRNAs have been studied for decades, but as a vaccine, that is new. And so the concept wasn't new at all. What the pandemic brought together is a ton of resources, dollars and money to many, many companies across the world to develop a vaccine. And then the trials and the testing all were done to standard. And what we've accepted risks on as a country was we were scaling, and we were getting the actual manufacturing going in parallel with the vaccine development. And a pharmaceutical company would never do that. That would be cost prohibitive for them to gamble that this vaccine is going to work and people are going to buy it. So we basically threw a ton of money at the industry. And then General Perna and Operation Warp Speed, where they made their money was pushing that money that way and supporting the clinical trials and across the country. But where they really made the money is having the factories developed, having the scaling and the tooling, and such that when Pfizer got its EUA, I think on a Friday, that on Saturday, trucks were rolling out with millions of doses of vaccines. And so what we were able to cut time off of, what the country cut the time off on, was the manufacturing once you developed it, and the scaling, and then the ability to distribute this amount of vaccine across the entire country. And it's put that the whole world was working that problem set together. So I know Operation Warp Speed doesn't bode confidence. I know that a lot of early on, there's, how long it takes to do a vaccine. There's no way you can do it in a year. But if you think about it, we had the entire world working on it with unlimited resources working at it, taking a technology that has actually been around for decades, and that's how we got there. So it's safe. And the last thing I'll say on safe and side effects are not the same thing. Side effects is part of medicine, and safety really talks about whether it is acceptable to put in a human body, and it is safe. Thanks.
If I could go ahead and talk about the anxiety and financial hardship, about the pandemics, fatigue and isolation. I just want people to remember to change their mindset, that we think too much about future planning and things that could go wrong. And if you start thinking about thinking that way, ask yourself if that behavior is helping you, and then go to your happy place, think of what can help. Think about the mountains, go outside, go for a run, because many people have had financial hardships, and that leads to anxiety, overwhelming thinking. Take a break from the news, and then get help if you need help. Seek your family, seek your friends, seek professional help. Getting help is not a weakness, and that's just something I really want to resonate with people.
Yeah, Cookie, I think that's a really important message. Is I think, throughout this pandemic, we've definitely had a myriad of emotions. And so to be able to say, I'm at my limit and I'm kind of burnout right now, please, I just need some help. It's definitely not a weakness. And it's definitely something that maybe all of us have had to think about over this past year. Are there any thoughts or resources on how we can support the mental health of our soldiers and our healthcare workers as we kind of continue on in this pandemic, because we don't know how long this is going to last right now?
Yeah, that's a great question. One of the things within the Army is there's always been a very strong propensity towards mental health, at least since the war has, since we've been at war for over 20 years. So for the operational Army, there are all these interests, there are all these programs, there's this focus, and I can tell you that hasn't let up. What is different is we really haven't focused on the healthcare and on the medical team. And so we're for Army Medicine, we're working on having a wellness. And it's one of our senior psychiatrists right now working with the team. And so you guys are the first to hear about it. We're working on a program. And the first thing is doing an assessment that is focused on all the experiences we just talked about. So we have things like BHAT that looks at operational organizations in a deployed environment and what their risks are and those tools. And we're actually working with the Walter Reed Institute of Research to develop a tool targeted specifically for military medical providers and our civilian workforce that have been in the MTFs. And in tandem, we're developing some tools for things that we know are going to come out that we all discussed today. Sleep, anxiety. I mean, we know that those are going to come out. But what we really wanted to do as we do our needs assessment is to get a sense of awareness for how prevalent it is, get some insight to what the team thinks they need, so we can better design a program that's targeting specifically that population. And so we're working on that with the Surgeon General and our behavioral health teammates for the Army Medical Department. So whether you're in operational Army or in an MTF, whether you're military or civilian, we're looking at the entire population.
Melody, I don't have the right answers. Some of the things that we've tried have been successful and others have not. We did do resiliency coaching for anyone that wanted it, frontline or otherwise, for employees at the hospital. But getting healthcare workers to go and talk to someone, especially in a small community, wasn't well received, and we stopped it after about 6 months for low participation. I think just acknowledging it, talking about it more is helpful. This is a population of people, those nurses and doctors' kids that don't come in till they're in septic shock, because if you're not bleeding, you don't go in. So I think just normalizing that this has happened to us, and that it's going to be hard and it's going to take time to recover is one of the things that we can do. Some of the hospitals in my area, but not mine, have given money as incentive, incentive in red areas, in COVID areas, paying back the salary that we took. One of the things that we thought was helpful here in Tuba City, we have a lot of traditional healers and medicine men. we did a cedar ceremony. And even for like non-native white people like me, I went through the ceremony, and it was just a way to come together as a community, and you know, it's not praying, I don't know that that's the word, but just acknowledging that we've been through something together, and that it's not done yet, I think has been one of the more helpful things.
Yeah, I know, even reaching out to other physician communities or other personnel that I'm working with, and being able to have those conversations, and sometimes just being able to vent about things that we're going through really helps with that. One of the questions that came about was, what career educational experience prepared you the most for the challenges you faced during COVID-19? And what leadership attribute did you find most beneficial in some of the difficult decisions that you guys have had to make?
I think one of the ones that trace back to actually West Point is you're part of a team. And the idea that when it's hard, if you recognize that you're part of a team and you leverage all the teammates, and you don't believe that it's just about how you're going to solve this problem, how you're going to work this problem, you know, that came through. This was ill-defined, right? You know, there wasn't, you know, we had our pandemic plans, all of us did. I imagine every hospital, but that plan didn't include the entire nation being subject to this level of intensity for this long. And so I think the thing that you learn at West Point is, and it kind of carries through, is if you try to get through this alone, it's possible, but you don't necessarily do it well, and it'll certainly take a toll on you. And so being part of a highly functional team, which I'm grateful that I am part of.
I would say the skills that I had that helped me lead, first was listening, trying to understand the problems, and listen to lots of different people's solutions, because we didn't have a playbook for how this was going to go. I think that listening and talking to other leaders and other healthcare organizations to see how they were solving the same problems. Like, we've all had the same problem, but we've figured out 100 million different ways to fix that problem. So I think listening was very important. And then to actually get the things done that I needed to get done in a civilian organization, different than the military that doesn't have a command structure, was follow up, follow up, follow up. There's lots of delegation and a lot of competing requirements. And the way that I was able to get things, you know, done from start to finish was, where are we on this? Follow up, follow up, follow up. It didn't require an MD behind my name. It didn't require 05 rank. It just required me asking the question and following up. So I think those were very useful tools that I had in my kit.
Okay, great, thank you. Another question from the group, does the Army have a program to encourage soldiers to get the vaccine? This is a good question.
Textbook answer, it's EUA, it's voluntary. We are doing, and I think we have to get out ahead and get the best information out. I mean, we're competing with a whole bunch of things, right? Social media, Operation Warp Speed. And so right now it's voluntary, and it really, really is voluntary. And so getting the right information, we have tons of PAO things out there, Stratcoms out there. We're leveraging young soldiers. We have a campaign, Get the Shot. So we're doing all the things to get the education out there. But to be honest with all of you, we have not targeted soldiers hard. We're about to, right? The first half of January, February, March, we were focused on, based on the same CDC schema that the country was using, we were largely using as well. And so as the vaccine becomes more available, we're gonna have to focus much more. Our next cohort to focus on will be the young, healthy soldier, and convincing them to get the shot. Someone I saw in the chat asked about the impact of COVID on the military. It wasn't on par with what it was with the civilian sector, and the answer is no. If you just look up our makeup, it's young, healthy people, so it didn't have the same impact and burden that it you know, to the same proportion that it had across the country. And that's for people in uniform. for our beneficiary population at large, even then, still, we take care of a disproportionate amount of fairly healthy resource individuals. And so it did not have the same impact, which is making the vaccine hesitancy conversation a little more challenging because they don't believe they're susceptible.
Yeah, I think, having those conversations with soldiers has been helpful, but it's not always 100%. And, I think we just need to keep having those conversations. But I think this rolls into a next really good question is, can you talk a little bit more about what you're seeing with efforts moving forward to respect to COVID long-term effects? So maybe our active duty population isn't seeing the same mortality rates, but as far as kind of the long-term effects of COVID, can you speak a little bit about that?
So the DoD has a registry. So we track every single service member that tested positive for COVID. And we have a registry where we'll follow them. And I hate to say the word study, but under surveillance, and we'll look for the long-term complications from COVID. But when you talk long-term to a 22-year-old, that's like next week.
I can tell you as a nurse in the hospital, we're seeing the patients coming back with these acute respiratory distress signs and symptoms. We're also seeing a lot of clotting. So I've seen a lot of strokes, a lot of heart attacks, a lot of DVTs that happen 6 weeks, 8 weeks after they're discharged from the hospital. So that's one of the things that, as an ICU nurse, has been tough to deal with. We actually get the one person who can walk out and they come back in with a stroke.
Yeah, Sarah, I was going to ask you too, if you guys had seen any long-term side effects from the population that you're taking care of right now.
We do. We do have some long haulers, and it's mostly they come back in for their O2 check, in the same day clinic. We're exploring the idea of sending EMTs out to the house because these people live in very rural areas and transportation to and from the hospital is very challenging. Usually it's a Medicaid or Medicare service that transports them. And doing that for COVID positive patients has been really hard because nobody wants to drive you around if you got COVID. So we're trying to check on their oxygen at home. We've done a pulse ox check, a pulse ox distribution plan at home through grant programs and other organizations that have wanted to donate money and stuff to the Navajo people. There's no formal clinic. We have a once a month, all of Navajo Nation people that want to participate and talk about long hauler symptoms and the patients that they're treating. So like physical therapy, the internist, family medicine docs, they all get together once a month and talk about what they're each doing across Navajo Nation at all of the 5 hospitals, as well as the numerous small clinics around. As far as our vaccine hesitancy, this disease touched everyone in the community, so it was a lot easier sell, I think. But the way we did it for our employees, because we actually had a lot of resistant employees, but now we're about 93% complete, 2-shot series for all the employees in Tuba City Hospital. We did town hall discussions where their favorite and most prominent docs were able to answer their questions for them, and they were shown a slideshow about the science and then given a whole hour to ask any question that they wanted. And that was very helpful. But actually seeing and touching and feeling the disease is one of the most powerful ways to sell the vaccine. And unfortunately and fortunately, we had that here.
So one of the other questions that I wanted to ask are, what are some positive things that you guys have either seen or experienced, either in your communities or that you've seen from the pandemic?
There's been a few. General Crosland talked about the teamwork. As a pediatrician, I would never have worked with the orthopedic surgeons or the dentists really closely. So that's been really cool to see as the chief medical officer, what everyone else is doing and how to reopen ORs and, how to do tables ready apps so that you can check into your appointment and then go back outside and sit outside. Working with IT to get fiber so that we can do telehealth better, because 30% of our patients don't have running water and 10% don't have electricity. So Zoom visits just aren't a thing out here. And so trying to work with all of these different entities all across Navajo Nation to make it a cohesive effort, especially as the money came in. I think Navajo Nation got something like $600 million. And what they're going to do with that money to support infrastructure like water and internet, being able to talk to the schools about how to Zoom with kids that don't have internet at their house. I mean, this has just been it's been a really wild ride. So I've gotten to learn a lot of new things and work with lots of different groups of people that I would never have touched normally. And then of course, all of the support, Navajo Nation in its infamy as being, more disease than New York City, we got a lot of support coming in. So I ran like a PPE drive out of my PO box, and I was just inundated with thousands and thousands and thousands of masks, gowns, shower caps. People from all over the world had seen my Facebook post that we needed PPE. And so it was just really, really heartwarming to see how the country came together to remember Native Americans for a while. And so that was really great. There's been a couple of NGOs that started. We had Sean Penn come out with his core team and bring us some money and do some testing. We had Doctors Without Borders come out. My whole career as a physician, I've wanted to be in the Doctors Without Borders. I thought it was so sexy, and then here they were asking me what I needed on Navajo Nation, this place that I've been living and working for the last 7 years. And so I just got to work with some really, really interesting entities and made some lasting friendships and connections throughout the medical community outside of my little microcosm.
I think a couple wins for us, like Sarah, the use of virtual, don't waste a good crisis. We were moving incrementally, and now we've powered through some of the no's because we had to. And so sustaining that is I think, important. I think for us as a military health system, it's unusual for the medics to be on the tip of the spear, but unquestionably, the medics were on the tip of the spear. And when I say medics, that's everybody that's medical in the Army medicine. And what many of our teammates didn't see was all of that understanding being forced upon our Army senior leaders. And they're better understanding what our role and purpose is. And it's forcing us to challenge ourselves on thinking that, what do we do about if we're going to be the response to the whole of government, right? They labored with us on those decisions on moving a resource from a hospital in a community to another hospital in another state. They start to understand the tension between rationalizing medicine, which is something typically is kind of glossed over, right? We don't really talk about that. There'll always be enough. You'll always, and so at our more senior level, there's a clear recognition that that's something we would have to think through in a large scale operation. And so there was some value in a live fire exercise where the entire healthcare system was under strain, and you still had to deploy, you still had to respond to emergent requirements, and you still need to take care of the team that's doing all of that. And that wasn't just seen within Army medicine, that was seen within the Army. And so we were glad we were recognized. That's a good thing, but more importantly, it now just gives a better understanding and sense of awareness at the most senior levels on resourcing for that requirement. As an example, understanding how we change our structure and what that would mean to have the ability to respond to a pandemic, because nobody actually asked us what we had. It was big global. You run hospitals, DOD. Is that true? Yes, we do. All right, this is what you're going to do. And then we kind of had to back into, here's our capacity. But that forced a deeper conversation and understanding within our Department of Defense. So value added at the strategic level. Also presented lots of opportunities to grow and do better.
Yeah, we've definitely seen a lot of, just me personally experiencing letting soldiers call in and say they're sick instead of making them come into sick call, which I really appreciated, giving them some of that autonomy, and then doing some of these PME courses online, and being able to still keep online learning and still keep the knowledge going, even though we're in the middle of the pandemic. One of the questions I had for you is, you all have very different paths to your current profession. Are there any messages that you want to send to West Pointers that are considering a career in healthcare?
So ironically, I just talked with all of our medical course, all of our doctors that are family docs. I'm a family doc, and there was a conference today as well, in a certain general talk. And the uniform message is, and I think Darlene talked about it very well, you're trained to be ready to do this. And that has to be a true statement, because there'll be a time when we need you to be trained and ready to do it. So if you're going to go into healthcare, you want to be really, really, really extraordinarily good at what you do, first and foremost. And there will be leadership opportunities in that environment, and bring value to that environment. And then as you grow and you move up and move in different positions, that perspective will shape you. And the last thing I will say is that perspective will shape you. But what we've heard tonight is it really took a team and different perspectives in order to get it done. And so you have four clinical folks talking about the clinical perspective. But I think you heard from all of us, whether it's a board of directors, or whether it's an operational leader, or whether it was new nursing students, we had to figure out as leaders on how to bring that together to get it done. And so be extraordinarily good at what you do, and like it. Actually, I'd say love it, because if you didn't love it, anything we just discussed tonight would be absolutely miserable. And while it was hard and it was difficult, I'm hard pressed to say I was miserable. It was hard, but I'm very proud of all the work that we've all done. Thanks.
I want to give a shout out for the nurses, because when I graduated from West Point, I was going to go to medical school. And then after I lost my husband, when I had a 9-month-old, I decided, well, I'm going to be a nurse, and I'm going to be a good nurse. I'm going to be a leader. And I thought I was failing by not becoming a doctor. We all have these perceptions that we're West Pointers and we have to be the best. And I actually believe I've made such a difference as a nurse. And I want to encourage other West Pointers, other service academy men and women to join the profession of caring, the profession of healing, and the profession of actually hands-on taking care of that patient and making a difference. What we do is invaluable, and how we help each other as a collaborative team with the physicians and providers is amazing.
Thanks, Cookie. That's great advice. I would say the first thing is there's time to get it all done, right? So if in a 20 or 30 or 50-year career, you don't have to do it right away. I felt this tremendous pressure to finish West Point and get to medical school and get out of school to practice medicine for the next 30 years. I'm so grateful to have had the experience as a military police platoon leader, officer basic, captain career course, all of those things in my deployment only added to the type of student that I was at Uniformed Services. Yes, I was older. I was a veteran, a Iraq War veteran, but that helped prepare me to take on the course load and the challenges as a student better. So don't be afraid to take that detour and do something cool that calls to your heart. There's probably time to get all of it done. And then second, don't be afraid of the hard work. These jobs are hard. The training, whether you become a nurse practitioner like Cookie, or a physician, the road is long and hard, but don't be afraid of hard work. West Point has prepared you, and you will find joy, confidence, and satisfaction in doing that hard work.
I think those are all really good points. I think, really finding what you're passionate about and pursuing it. And, still at the same time, remembering that have fun along the way too, because it's always going to be like, I'm working towards this next goal, but when you get there, maybe there's going to be a next goal or not, but making sure that you have kind of enjoyed the journey and the path along all of that. Are there any other kind of burning topics that you guys want to talk about, or things that you definitely want to make sure that we address tonight about the COVID pandemic and the response?
I think I'll share that we've talked quite a bit about what we did professionally. I'll spend a minute on some personal challenges, right? I have shared with all of you, besides Ike that said hi to all of you, I have 11-year-old, and the thing that actually stressed me the most in the beginning was him not being in school and figuring out what we were going to do. And I had childcare covered, but the schools were, and I'm in Fairfax County, I think they did as good as anyone could have done, but it was incredibly disjointed. There were packets, and I'm stressing out over doing 4th grade again. I mean, working these incredibly long hours, and now I'm coming home and I'm trying to figure out what his requirements are in school, and killing time on the internet. And it was just that was actually way more stressful than trying to figure out a testing strategy for the Army hospitals and clinics. It was difficult. And then keeping him engaged. I'll admit I'm grateful and very blessed that my little boy he kind of rolled with it. He treated it like, and he is still treating it like it's just a prolonged summer break. And as he goes back to school twice a week, I'm happy he's not. But I do worry, and I am concerned, how do we get back into a routine? I'll openly admit again, I probably didn't maintain. I would have, if I could live it all over again and be perfect, I'd have kept him on a school routine. I tried that, guys. It did not go well for me. You're going to get up, you're going to brush your teeth, you're going to eat breakfast, you're going to make your bed, you're going to get dressed, and you're going to come to study and sit on a computer for 5 hours. That's what we're going to do. Everybody got it, break. That's military mom. And I come home and everybody's in their pajamas. But he did sit on a computer. So that was difficult. It's much better now. I think the school's got a better rhythm, and they stopped trying to do everything. And they kind of, at least here, they collapsed down what they could actually do with him, with his class, while they were in school online. And I found that immensely helpful, because then he had advanced to the 5th grade, which I didn't want to do 4th grade again. And I certainly didn't want to do 5th grade again. So I just want to share that. Thanks.
No, I can absolutely relate to that. I have a 5-year-old son who is starting school this year, and our family care plan essentially fell apart because my parents are in Pennsylvania, and so we couldn't have them come to help. And so, yeah, really finding ways to kind of overcome those challenges. For Cookie or for Sarah, do you guys have any closing remarks that you would like to share?
Thank you guys so much for inviting me to speak. I hope I get to see you in the flesh soon. I know that Zoom is exhausting, emotionally, mentally exhausting. And thanks for spending your time with us, and reach out anytime you have questions or just want to talk about life.
And I guess all I'm going to say is wash your hands, wear your mask, and respect others' safety.
And of course, we've got to say beat Navy.
Beat Navy.
Beat Navy.
Thank you so much for joining us tonight. Thank you so much for your words of wisdom. Thank you for sharing your stories and being vulnerable, so that we could really talk and kind of, just share. I think, when we talk about loneliness and, isolation, and being able to have this community of West Point women has been so important to me over the past year. And so I really appreciate everything that you guys are doing.
Melody, Sarah, Cookie, General Crosland, thank you so much for investing your time. It means a lot to our community that you were willing, that you answered the call. We didn't even have to hound you guys. You answered the call and were willing to help us out with this. And you're seeing the comments. You've made an impact tonight, and I hope you feel that way, and that the time was well spent. Whether it was talking about the stories of heartache, of bravery and courage that you saw in your peers and in the people that you cared for, or just thinking about where we've been and where we're going in the future, or how we're getting through this through listening and building really effective teams, and how we're dealing with the burnout. All of those are valuable lessons that I'm personally taking away from this. So thank you so much on behalf of West Point Women and AOG for giving up your time this evening.